Good evening. My name is Irene Lang. As you can see, I'm very pleased to be with PAH Europe again, virtually, and maybe we will have a discussion on March 13 on the future of pulmonary arterial hypertension. Maybe pulmonary hypertension, but I was asked to talk about pulmonary arterial hypertension. Here's my conflicts of interest. And I chose to start with a brief history. If you talk about the future, you have to talk about the past and the present. And this is what I tried to summarize here quickly. And it's a story about prostacyclins, but may become a completely different story. In 1976, there's this famous Moncada, Sir John Vane observation that microparticles from vessels support the catalysis of endoperoxides and confer vasodilation and platelet anti-aggregation. And then you see that in '82, Lou Rubin, Dr. John Reeves, and Dr. Groves found the drug useful in 7 patients with pulmonary hypertension. They gave the infusion briefly and observed some longer term improvements. Tim Higginbotham really changed the surface of pulmonary hypertension treatment because he installed chronic prostacyclin, epoprostenol at this time, treatment in a woman who couldn't get out of her bed anymore. And Professor Lou Rubin carried on the story of prostacyclins and PH treatments with an open label trial and observed the dramatic reduction of PVR. Brian Christman put the science to this and showed that metabolites of prostacyclins were dramatically decreased in the urine of patients with primary pulmonary hypertension at the time. And then came the FDA approval for synthetic prostacyclin epoprostenol. And then came Robin Bast with her pediatric pulmonary hypertension treatments with a very first 12-week randomized open label trial that showed a benefit that was dramatic. And no wonder this is a great treatment. Then came Bosent, and then came all the other treatments. And those are shown here on this slide. And we are looking into where we are going now. You see here the epoprostenol story that went over a couple 10 years before 1995, as I mentioned. Then there's Bosent and iloprost, treprostinil, sildenafil. And with treprostinil, there became a new era of using both subcutaneous, both IV, inhaled, oral, any way to get prostacyclins replaced or supplemented or whatever you want to say in those poor patients without prostacyclins. And you see there's the inhaled in 2009 approved and all the other medications. As you can see, all vasodilators, no approval for any other principle of molecular mechanisms in this condition. And maybe this is where we are going, but let me first be more simple. Here is what I want to talk about. The future of PAH. I want to talk about genetics, natural history. I want to talk about hemodynamics and show you some interesting things. Imaging, about risk, because risk is everywhere. Everybody wants to classify the risk status of your patient. It's a good idea for regulators. So maybe some more philosophical thoughts about risk. And then also treatments and strategies, which is always what matters for patients. Let me talk first about genetics. And we all know genetic testing is gaining more and more grounds in any cardiovascular disease. It was always less in cardiovascular than anywhere else, like in hematology or other disciplines, like in pediatrics. Genetics is more important, but coming now to us. Why? Because genes have been discovered both by the NIHR bioresource movement as well as by the PVDomics. The genetic emphasis has been made. And the basis is the observation of the BMPR2 downregulation, which is everywhere in any condition of pulmonary arterial hypertension, is consistent downregulation of this pathway. And the formal definition of this deficiency is shown on the slide. BMPR2 is a membrane receptor for the TGF-beta signaling cascade that speaks with the SMAD, SMAD4, and then SMAD, and the rest of the SMADs. You will see that in the next slides, and signals to the nucleus which RNAs to make and whether to proliferate or to stop proliferation. And this seems to be mutated in families with hereditary pulmonary arterial hypertension. The ligand for this BMPR2 ALK1 complex is, for example, BMP9, the bone morphogenic protein 9. But there's others. There's endoglin, which also belongs to the TGF-beta family. And there is ALK1, which is another member, usually mutated in the Osler's patients. And other membrane receptors like caveolin-1 or the KCNK3, which is the TASC1 receptor, a potassium receptor. And then outside of all this membrane stuff is the intracellular EIF2AK4, which is a very poorly understood, but maybe some people know more than I do, protein that has to do with ribosomal protein synthesis under conditions of stress. And the question is, how can we impact that? We can modify BMPR2 with BMP9. We can decrease BMPR2 degradation with hydroxychloroquine, which is a known drug. We can work on the inhibition of TNF-alpha with etanercept. We can enhance downstream signaling with FK506. I will talk about this briefly. And then we can restore the KCNK3 dysfunction. Maybe we can do something to the EIF2AK4 as well. Not so well developed yet, but anything that comes from this pathway is very promising. And this is because it's a common mutation in this rare disease. It's been studied well. We know it's reduced or loss of function, decreased function. We know there's a connection with estrogens. We know that there's an effect on apoptosis of endothelial cells. So it makes a lot of sense to target this pathway. And I think the most substantial research has been done by Ada Spiekerkötter, where she penned a library of FDA-approved drugs against a vector that was indicating the upregulation of BMPR2 in a model system. She actually used a mouse model and showed with FK506, which she penned out of this drug scan, she could prevent vascular remodeling, as it's shown here. And this is vehicle on the right side. So very successful, also done in humans, where the primary endpoint was the regulation of BMPR2 in circulating monocytes. She could actually demonstrate that BMPR2 was upregulated in monocytes by FK506, but she couldn't alter current parameters as secondary endpoints in this patient population, which was expected. So things are going on in this field. We haven't heard recently, but we are very positive that one of those approaches will work. So if you look again on this panel as a central module in the PAH research of the future, there's news. There have been drugs that are called ligand traps that capture these activins. And it's called here a rebalancing of the BMPR2 pathway. They actually decrease the pSMAD and increase the pSMAD158, decrease pSMAD23, increase pSMAD158. And these drugs, one of them is sotatercept, are coming along, will be tested in a phase 2 trial, phase 2B setting in pulmonary arterial hypertension. And they came from the thalassemia research, where these ligand traps have been used to decrease growth differentiation factor of 11, which is one of the obstacles in erythrocyte hematopoiesis and stalls the erythrocyte development. So if you take out growth differentiation factor 11, you are able to modify erythropoiesis in thalassemia very successfully. So the goal in pulmonary hypertension is what was shown in the first trial, which was called PULSAR, that the drug acts in a vasodilatory way. So sotatercept and standard of care, which is SOC, was able to decrease PVR by 160 dynes at the 0.3 milligram dose and by 260 dynes at the 0.7 milligram dose. So there's those findings ongoing, clinical trials ongoing in this area. So the other interesting innovation is in the field of hemodynamics, and I have a particular interest in that. Imagine that the healthy pulmonary artery is very elastic. It has a Windkessel function, meaning in systole, the wall stretches, in diastole, it comes back with a energy emitting recoil function, and this pumping function allows the right ventricle to work against zero resistance. That is gone in pulmonary hypertension. And to illustrate this, you see here a cross-section of a healthy pulmonary artery that's all green, stacked with elastic fibers. And in the case of pulmonary hypertension, elastic fibers are all broken. It's all collagen. It's all different, not very stretchy, but stiff fibers. So Windkessel is dead, doesn't work anymore. And a very interesting new idea is that the Windkessel function, if lost, leads to a high pulse wave that destroys the capillaries. And the same thinking is the basis for this manuscript, where the authors say hemodynamic unloading, taking away the high pulse pressure, may reverse occlusive vascular lesions. They did it in an animal model. And there's more to this in the literature, that the unstiffening is delivered by reducing the pulse wave. And that is what happens through vasodilation to a degree. But that is also addressed by a new medical device, which is called the ARIA medical device. And that is a device that is focused on the decrease of stiffening and increase of compliance. It's a breakthrough device by the FDA, and I will show you what it looks like. We tested it in Vienna in the first-in-human trial. It was actually a first-in-human study. There's a reservoir with a gas that comes through the conduit and inflates a gas-filled balloon. The model that's shown here is a permanent device. It's anchored in the pulmonary artery and inflates and deflates. You see here, this would be the implanted version with a little reservoir, a line, and the attachment to the pulmonary artery. So the ARIA device mimics the functioning Windkessel system by maximizing cardiac output and minimizing cardiac work. And I will show you immediately the pulse curve. In red is the normal curve. And if the balloon is working, the pulse pressure decreases and the diastolic pressure increases. And it's not so easy to understand in the beginning, but if you look at the first-in-human study and I'm sorry, I jumped. This is my university. We did it in 2017 already. We looked in 10 subjects of group 1 pulmonary hypertension in classes 2 and 3 on full medical treatment with prostacyclins. And we used this version of the balloon that was attached to a gas reservoir in the cath lab. And we had 2 pressure wires in there to measure all the resistances and pressure in these 10 patients, 50 years old. They had been on treatment for years. So there were very lucky people who survived years of disease, had still a mean pressure of 49 on medical treatments. And we had a very good clinical series with them. And this is shown here. The cycling balloon is seen in on the left side in a lateral view, on the right side in an AP view. So this is a balloon that is passively inflating in diastole and deflating in systole. The principle of the intra-aortic balloon pump. And you can see here the analysis that was recently published not very long ago, where device on, device off is red and blue, and you see rest and exercise. We had the patients exercise. Both compliance increases and coupling increases. This is coupling that was estimated by single bead analysis. So in summary, this is a completely new concept of decreasing pulse pressure and releasing the stiff pulmonary artery into a new, more Windkessel-like biology and physiology. All right, so our next on the list is imaging. So that's easy. Imaging is not working as we want it to work. Look at this. This is a micro CT of a rat lung. On the left side, it's a normal rat lung. On the right side, it's a monocrotaline rat lung. And this was kindly given to me by James White, who has experimented with this model for a while. We have still not got to this type of resolution. You see the little branches, they are gone. All these nice fluffy capillaries are gone in the pulmonary hypertension condition. And if we were able to see this early without the right ventricle being compromised, treatments would start probably 15 years before today's start of treatment. I'm very positive. I mean, I don't know, of course, but I have a lot of imagination, and I submit to you that this may be the case. So there's a recent CT simulation of the arterial and venous bed in the lung. I think this could be much more detailed in the future, and we really need this. Same for the right heart. The right heart is so complex. It's not a banana and it's not a pear. It's a very individually shaped, and in pulmonary hypertension, particularly individually shaped geometric module that contracts in a not so easy way. And once we understand this, we will be able to phenotype the RV. And some groups have already done this. You can see that on my slide, which where I've pulled a lot of information just to show you. Some people do fluid dynamics, some do molecular characterization of the ventricle. Some use circulating markers. Some use moving images and try to reconstruct the phenotype of right ventricles by MRI technology. So this is another interesting aspect. But in addition to the imaging aspect, I want to talk about risk, because as I mentioned, the ESC guidelines have really been very proliferative with this traffic light of risk assessment. And it was put together in a apparently systematic way, which is a real strength of the ESC guidelines in general. They are very able to make complex things quite simple by extrapolating. This was nicely extrapolated here. There were several big registry like ESPA, the Swedish PAH registry, or Compera, the German registry, that computed this is an example here, they did a sum of grades. They divided the sum of grades from these 3 areas by the number of variables. And then this was calculated as risk categories. And this was nicely reproduced. You know, all this literature. This is the ESPA reproduction. This is the comparer reproduction. This is the French reproduction. So it works. But is this what we want to work with in the future? No, because we need more evidence from imaging to guide treatments. And recently there is more evidence for imaging to guide treatments. And Roberto Badagliacca and the Italian IPH network have put all that data together to show that unless you lower the PVR by 50%, and unless you lower the mean pressure below 40, and by more than, you can see that here, by more than 25 to 50%, you're not going to survive. And if you do this, the right ventricular end-diastolic area is also getting smaller. So imaging, and this has also been shown by Anton von Knodegraaff originally with MRI, imaging is a very important component of risk categorization. But we didn't have the data up to now, but many groups in the world are now focusing on this missing link of imaging. If you have a low pressure but a big right heart, that doesn't help you. So imaging must be in concordance with BNP pressure, right atrial pressure, NYH class, and 6-minute walking distance. Unless that is the case, you cannot calculate risk well. So what about new treatments? I want to remind you of AMBITION. AMBITION was the study that showed if you combine, and this is the endpoints of AMBITION, very important endpoints. If you combine two treatments from the very beginning, you're doing much better than the pooled monotherapy. And there was a 50% risk reduction. A reiteration of this concept was done in TRITON, because we said 3 treatments may be better than 2. And this was the endpoint, the initial first-line dual oral of endothelin receptor antagonist and BDF5 inhibitor is a standard of care, but can we add an oral prostacyclin to make this better? No, we can't make it better. And there's a lot of theories about this. There's a signal of improved outcomes if you look far beyond the original study endpoint, that initial triple may be better than initial double. Of course, there's other thoughts. What about if you use a prostacyclin parenteral, as I pointed out to you from the very beginning of the story? Many discussion points here. I would think if you add a prostacyclin in addition, you will be able to make the stiff system smoother, and you will be able to reverse, remodel your arteries. As shown in this example from Professor Matsubara, as a young woman, 33-year-old non-responder lady, was put on prostacyclins, and you can see also bosentan sildenafil very early on, and normalized. That's the dream patient that we would like to all, as physicians, we would like to see that. We would like to see a young woman becoming normal in her pressures. And that may be by aggressive upfront triple combination. Of course, there's other approaches. One is the repurposing of approved medications. There's one example is the anti-IL-6, didn't work. The beta blockade didn't work. Spironolactone didn't work. Estrogen inhibition, we don't know yet. It's a very convincing concept here. You see, this is a Chinese study from the European Respiratory Journal, where the blockade of the estrogen receptor actually in the BMPR2 mutation led to a reverse remodeling. And this is the pathway that is suspected there. This is James White, the author. So there is some intriguing truth about the female phenotype of PAH that might be a treatment target. Anastrozole is one of them. There is a rituximab study ongoing where we want to block B cells. There is rodatristat, there is L606, and PhaseBio. I just discovered that there's a misprint. I will correct that in my final presentation. And there's a Sapphire trial that is aimed at transforming or transfecting eNOS transfected EPCs into patients with pulmonary hypertension. That's probably the most complicated concept, is to replenish the lungs from what they don't express, which is vasodilatory endothelial cells that are expressing the eNOS and produce NO, which is a very important vasodilator. And there's more to the treatments. I was jumping over all these studies because I don't think they are prime time yet. It's just an information for you that we work very hard on new ideas. What has been published, though, is, and that has been around for some time, you see this is from 2013, that pulmonary artery denervation may be a way to lower the pressures. And you see here the radiofrequency catheter that Shan-Liang Cheng is using and has been showing the world. He's putting it into the left pulmonary artery because of the distribution of neurons that regulate vascular tone. In the Trophy-1 study, another system was used, which is ultrasound-based, and you can see here the key information of the primary endpoint. Pulmonary artery pressure went down in this is systolic pressure in this Rothman Czech cardiovascular imaging publication. Raises some hope that this may also be a strategy to go. And one of my last new topics is WHO Group 4, the chronic thromboembolic pulmonary hypertension subset. There's also news here. It's a disease, as you know, that's really primarily subjected to pulmonary endarterectomy, but half of the patients get either targeted medical treatment or BPA, the balloon pulmonary angioplasty, surgery, medical, or BPA is the triple offer of physicians. This would be an example of pulmonary endarterectomy shown on the slide. This is an example of imaging with webs and pouches, and C-arm CT can very nicely demonstrate what you cannot even see on digital subtraction angiography. So we're moving along in the imaging in this disease. And there's also a very recent, you see, it's not 2010, I'm sorry, it's 2021, was in JAC, a percutaneous denervation study in CTEF by a Russian group using this type of I think they had a radiofrequency catheter that they used with remote magnetic navigation, which was the asset in their study. So in 21 is a study on denervation in CTEF. Angioplasty, though, is probably a bit more refined at this time. It has been refined by Japanese investigators. You see the after balloon pulmonary angioplasty, the vessel is large, and 3 months later, even bigger. So this is an extremely promising branch of medicine. I'm showing you here the OCT image of an obstructive lesion that's dilated, and after dilation, all the material is squished to the side, allowing normal flow. And this is going to grow. I'm sorry, I'm going to take my laser pointer here. This is, I'm sorry, where is it? Laser pointer. This is much bigger in 3 months, as you saw. There is different lesions, rings, webs, subtotal and total occlusions, and we're increasingly starting to look at the total occlusions because the right ventricle is remodeling after BPA very successfully. And you can see here in this study from Vienna that the predictors of treatment response were the treatment of chronic total occlusions. And you can see that the number of untreated lesions impacts treatment success in a negative way. So we have to open every lesion. This is now a mandate for BPA. So we have to work like in the coronaries with a CTO toolkit to get through these lesions. And this is the last, I'm sorry, this last picture. I cannot make it run. Let me switch from my laser pointer to automatic, and then I can get it running. And you see, this is how it looks when it's all open, and it's thousands of capillaries that are regenerated this way. Taken together, I think the future, and it says PH here because it's a more global approach. Pulmonary arterial hypertension, CTEPH, maybe also the groups 2 and 3 that are so much more troublesome because of the mixed phenotypes. We want to personalize treatments with biomarkers, proteomes, SNPs, microRNAs, and our best and end of innovation strategies. We will be looking at individual patients and embed our future treatments in the modern biology, and by international networking get fast to a solution. This was really nicely demonstrated by the COVID epidemic, as you may know. There's also one downside to COVID, of course. COVID is part of our algorithm on how the second hit in PH leads to manifestation of disease. And you may have heard that SARS-CoV-2 infection is associated with thrombosis. This is clear, which we don't like at all because it may cause CTEPH, but it's also associated with release of cytokines, mitochondrial dysfunction, hypoxic vasoconstriction, apart from in situ thrombosis, which are all known to be cause of PAH. So particularly in those who have been very severely ill, we will have to look out that they don't develop pulmonary arterial hypertension. This is where all what I just said comes in, particularly the imaging is under scrutiny now to discover early pulmonary vascular sequelae of COVID-19. Still, I want to conclude. The future is brighter than ever. Why? New decisions with new data. We are more aggressive. Finally, new drugs with human PAH data. Think about FK546. New drugs with active testing. Please think about sotatercept. And better imaging, earlier treatments. This is a real major mandate to think. And then, of course, worldwide, genome-wide approaches. We need to grow together. Centers need to talk to centers, and patients need to talk to patients. But the main thing is that the science has a worldwide connection, despite all travel limitations. Hope this was interesting, and looking forward to your questions.